So I was one of those people who decided very early on, I think I was 6, that I wanted to go into medicine. So I grew up in inner city Chicago, loved school. School was my refuge. It was the place where everything was safe and predictable. And so I was already primed for science and school. But one day a plastic surgeon came to our school for career day and brought a raw turkey leg and a scalpel and some sutures. And she sliced open the turkey leg and then sewed it back up again. And she said, "This is what I do." And I said, "That's what I'm going to do. I'm going to be a doctor. It's going to be great." So that was age 6. It did not change my mind, but the reasons for wanting to go into medicine thankfully matured over time, as I did. Got to college and realized that I was really still very committed to health and science. And I saw medicine as a way for me to contribute to health and to the betterment of society, but also use that part of me that really loved science. So medicine was a natural inclination for me. I was headed into OBGYN because in college I was a sexual health peer educator and an HIV counselor. And I really still love talking about sexual health because I think it's something that's so important to our own lives and how we move through the world and how we navigate relationships, but we don't really talk about it very much. And so OBGYN seemed to be a good fit, but I went to medical school and I fell in love with everything. Every single rotation. I'm going to do this. I'm going to do that. I'm going to be an endocrinologist. I'm going to be all of the things. And so when you love all of the things, I think most folks tend to go into medicine. So I'm thinking, okay, it's probably going to be a branch of medicine because I love all the things. And then I ended up in the OR on my anesthesia rotation. And the moment where I think it started to click for me was I was in a case, and it was a few days in. I was having fun, sort of meeting everybody, but we were watching this patient who was under general anesthesia, and their blood pressure went up. And I said, "Oh, we should give them fentanyl," which is, an opioid drug. And the resident I was with said, "Why?" And I said, "Well, that's what you do when the blood pressure goes up." And they said, "Well, why did the blood pressure go up? Did it go up because they don't have enough anesthesia? Did it go up because they're in pain? Did it go up because they tied off some blood vessel? Like, you have to figure it out first, and then you treat it." And I said, "Oh, it's like medicine, but it's faster." I think I might want to do this. So then I started talking to folks, and I said, I think I might want to do anesthesia. And all of the anesthesiologists said, "Oh, well, that's a good decision. I would, that's great. I love my job." And even the old grizzled ones, the old ones that are just sort of crusty and crotchety, anesthesia's great. Okay. And then I would talk to other people in other specialties, and I'd say, "Thinking about anesthesia," and they would go, "Oh yeah, I would do that if I could do it all over again. I would do anesthesia." And so I felt like everyone was telling me to go into anesthesia. Oh, a typical day is the hardest question I get. When I show people my calendar, they sort of recoil in horror because every day is different. So it's more like what a typical month looks like for me. So a typical month is 1 week on service in the ICU. And so that's 7 days in a row where I'm on rounds in the morning, I'm writing notes in the afternoon, I'm sort of floating around, seeing patients, helping institute care plans, doing procedures. And then, in between moments when I'm with the patient, trying to read emails and work on research. But the other 3 weeks, I'm either doing research or I'm doing administrative work. So with my research hat on, I'm a PI of a lab that's interested in implementation science, basically trying to get clinicians to change their behavior so that they are practicing more evidence-based work. And then the other hat is the Vice Chair of Inclusion, Diversity, and Equity, where I'm trying to make sure that we are providing an inclusive environment for our trainees and for our staff, that we're providing equitable care, and that we're sort of making sure that we reflect the population that we're trying to serve. So mentorship is hugely important, I think, for lots of reasons. One is that you need cheerleaders to kind of cheer you on. And I think especially, for me, for someone who looks like me, it's very easy to think that you don't belong. When you look in medicine and you look especially in science and you're like, well, there's no one who looks like me, maybe I don't belong. And then you have someone who goes, no, you do. Like, you're good. I remember in college I had a biochemistry professor who, to this day is one of the most influential people in the development of my identity as a scientist. She would come up with songs about the Krebs cycle. Like, she loved biochemistry. She had me fall in love with enzymes. I'm like, they're so specific. How do you do it? That's amazing. But she also, like, when I told her I loved biochemistry, was like, yeah, great. Let's go. Let's do it. Let's do more. This is wonderful. You want to be a doctor? That's great. So I needed that cheerleader. And I think you need that cheerleader sometimes in your career to keep going. But you also need people who have a sense of how the world works, how to help you navigate through it, how to maintain your enthusiasm, but also help ground you a little bit. Because sometimes you can think, oh, I'm going to take over the world. And they're like, hold on, wait a minute. Like, you'll get there, but slow down. Do this first, that first, this first. And you're like, okay. They give you a sense of sort of how to navigate. They help you figure out your roadmap. And then eventually, hopefully, you have mentors that either transition into sponsors or give you access to sponsors who can open doors for you. And that last piece is crucial. And I think women and minorities in particular tend to have lots of mentors who they can go to and sort of ask day-to-day questions, and don't have as many sponsors who will vouch for them, who will make a call for them and get them on a committee or nominate them for an award or do all of these other things that you need to kind of make your career keep going. So I'd say for me, mentors and sponsors have been really, really important. But another piece too is that I think you have to have an open mind as to who can be a mentor for you. And again, I don't want to harp on identity too much, but I will keep coming back to it because it's sort of a common thread. Most of my mentors don't look like me. And so if I were looking for mentors that looked like me, I would be out of luck. Most of my mentors are old Jewish men. That's just how it happened to pan out. And it is what it is. Like, they're invested in me, I'm invested in them, and we connected over a common academic interest, and everything's worked out well. So, I think that key connection and that investment in each other is much more important, or it has been more important for me than that linkage to identity. Although I have also had other people who do look like me in other fields who, I can go to for support, and you go to them and you go, did that happen? And they're like, yeah, that happened. You're like, was that right? And they're like, no, that's not right. And you're like, okay. Like, you need those people to reality test with as well. So you need a family of mentors, really. If you really want to do this, don't take no for an answer. And I've seen a lot of my mentees be told no. Some of them listen, but some of them don't, and they just persist. And they're like, I'm going to be a doctor by hook or by crook. I don't care. I'm going to make it happen. And they make it happen, and it's great. I got really, really good grades in college. I was a double major. I was in Phi Beta Kappa, and I applied for med school, and one of my advisors said, I don't know if you're going to get in. And I'm like, really? And, I don't know where that came from, but every acceptance I got, I sent to him. And then when I graduated and I walked, he gave me, my little diploma thing, and he said, I'm sorry. I'm like, yeah. But, no matter how good you are, there may be people who tell you that you're not good enough or doubt you. But even if your academic record isn't perfect, and I've certainly had mentees where, college getting off, it was a rocky start, and they sort of had to find their footing again. But if this is really what you want to do, there usually is a way to do it, and you have to persist, and you want to surround yourself with people who will support you and give you positive energy and give you strategies for how to get there, and not just listen to the people that are like, maybe that's not for you. My drive for doing work in DE&I is related to the disconnect I have when I look at my overall life and who I interact with and what that world looks like. And then I look at the world of academic medicine. And I think about all the wickedly smart people that I know on the outside and the diversity in my friendship groups or my networking groups. And then I contrast that with what I see in academic medicine. What I see in academic medicine is a lot of very, very smart people with very constrained, narrow ways of thinking about the world, about themselves, about merit, and who belongs. And it's to our detriment in academic medicine that we don't have a broader sense of who should sit at the table and who can contribute. And so I think what drives me is that I see where we could go if we weren't so constrained by these historical notions of what people are supposed to do. And if we weren't so bound up in the idea that we should operate as a meritocracy, because we actually don't operate as a meritocracy. Like, we have this fantasy that we do, but there's so many exceptions to that. when I see people get into positions of leadership because so-and-so knows them and they like them, I'm like, how is that a meritocracy? So there's so many exceptions, demonstrable exceptions to that, and yet we still cling to this idea that you have to show merit in this very specific way in order to play. And I see how that harms us. So trying to bring those two worlds closer together for the benefit of our scholarship and our patients, I think is really what keeps me going. So I'm excited about the future for anesthesiology because I think in COVID especially, demonstrated that we're like a jack of all trades. Like we're the Swiss Army knife of medical professions. I feel like we can kind of go anywhere and do anything. And we've really demonstrated our value. So I'm excited about where the field is going clinically. I'm excited about strides in intensive care and in pain management. I'm excited about where we're going in perioperative medicine and management. And I'm excited about the research directions that I'm seeing people take. So, I think if we continue to embrace our identity as perioperative physicians and sort of acute care physiologists, I think we'll do great. I have always thought of anesthesia very expansively, and that I attribute to one of my mentors, Lee Fleischer, who was the former chair at Penn, who was another one of those, like, we're going to do everything. Like, why wouldn't we be in the outpatient setting? Why wouldn't we be everywhere in the hospital? But I think to the extent that we take on that mantle of we can do anything and be helpful anywhere, then our future is very bright.